using our specific example in Lagos, that's where we have a partnership. Our partnership is backed on the one hand by private hospitals in the south, but by institutions in the north, here in Switzerland, for example. But coming from that region of the world, it was easy to liaise between the two places and work together with the two institutions. What usually works is, as usual, there's a saying, there's an African adage that says, if you want to go far, if you want to go fast, go alone. If you want to go far, go together. So it was very important that, have all stakeholders on board doing such a job, number one. Number two, we also realized it was very important not to neglect the resources on ground. It's one thing to have the institutions. These are usually conventional medical facilities. Our project had as a target integrating the traditional medicine and conventional medicine, a much more complex background. So all the more the necessity to get all the people on board. And your partners, your stakeholders are not always on the same level. So there's a lot of capacity building to be done among others, our targets, the traditional healers, traditional birth attendants. They need to be at a level where when we speak the same language, so to speak. And especially when we want to work together, collaborate together, we have to be on the same level to respect each other, and so that the clients that we're all going to serve know that we respect each other. So this aspect of capacity building is number one. Number two is naturally also to involve the populace, the community that finally we want to serve. They also need to understand how come this is new. These are our trusted people, the traditional healers and birth attendants. These people, we know who they are, the conventionalists. They never treat us well, and so on and so forth. So it is important also to inform the populace. And in order to do that, it's not enough that we go there. We absorbed people from the community, especially the youth. We absorb the youth, also train them so that they go back to the community to make awareness raising within the community on health matters and health issues. So there are different levels of activities, and we had to bring all involved to the same level so that we speak the same language and then understand each other. That is basically the main, using the resources on ground, make sure we all speak the same language, and always make sure that all stakeholders, including the state, of course, are also involved. Now, what doesn't work, because that is usually also very, very rampant, our partners told us there are three main obstacles anywhere south of the Sahara, whatever program, whatever project, whatever business you want to do. Number one is, obstacle or constraints is, on the one hand, your logistics of organizing where, what, and with whom you want to achieve anything. Number two is your financial constraints, the economic background. And number three is, unfortunately, the most important, the governments. They're always an obstacle. So it is always very important that they are on board from day one, because without them, nothing works. Or then we have difficulty with implementation on ground. This is a short summary of it. Thank you.
Thank you very much, Dr. Da Silva. I forgot to present actually the speaker. Dr. Da Silva is from the Verein Support and is running a project in Nigeria. And all of the panelists, they have a project supported by Esther Switzerland. So that's why we choose them, and that's in order to also to have a vision from people running project on the ground. And now is to David Bern from the Cantonal Hospital in Geneva, and he has a project in Peru.
Thank you, Luciano. Yes, so my name is David. I'm from the Geneva University Hospitals and the University of Geneva, and my project is with Salud Sin Límites, which is an NGO in Peru that's focused on community work across topics, and also an academic institution, Universidad Peruana Cayetano Heredia, which is based in Lima. And our project is focusing on HIV/AIDS and STIs in the Amazon, and specifically in indigenous populations, mainly because the burden is much higher in the indigenous populations than in the general population. So overall in Peru, the HIV/AIDS prevalence is 0.2%, whereas in this specific area in indigenous populations, it's 7.5%. And within this context, there's specific issues for the population in terms of migration, especially of young people. It's an area where there's a lot of mining companies, and it's complex in terms of the social structure. So our project is relatively new. We started in March 2018, and coming back to this issue of partnership, we have an existing partnership with our academic partner in Peru through an R4D project supported by the SNF and SDC. And for that partnership, we already spent a lot of time building on the KFPE 11 principles, and that also served as a guiding sort of structure for this partnership. Coming back to Luciano's question, I highlighted three areas in terms of this partnership. One is the people, the other is the topic or target, and the third was the approach. In terms of the people, it's how does this build on existing partnerships, existing links, friendships even, but how does it also lead to new partnerships? So for example, a partnership between a Swiss hospital and a local NGO, and also new partnerships and new approaches for the NGO as well, in terms of the topic, in terms of the population, and in terms of taking very much a health systems approach when their focus in the past has been more on communities. And what this all means is different interactions and different perceptions on the problem, coming from a very academic perspective to more of a community perspective and all that. And how does that mean different people need to come in? And coming back to your point about language, is that different people speak different languages, not only in terms of the languages that people speak in these indigenous populations, but also that speaking to a community about HIV/AIDS is very different than speaking to healthcare workers. And what we found is that's one of the barriers, is that the healthcare workers don't speak the same language, both the linguistic element as well as the descriptive element to these populations. And coming to the topic or target is also the population. This is a specifically defined population that is facing a variety of challenges, both social and economic, based on where they are. As I mentioned before, this is taking a health systems approach into a context where one of our partners is always focused on the community. And then for me, it's a different topic area. HIV, STIs is not my area of expertise. My area is more health systems and chronic disease. And so how does that transition also have to happen in terms of the approaches and lessons learned? And that leads into the third element, which is the approach, and how does the expertise that comes from the different partners build together? How do we bring in this health systems expertise, working with communities? And again, this is where the previous partnership with our R4D project has been useful, is that we've been able to use some of our approaches from this project, which focused on linking communities and health systems in this project supported by Esther on this specific topic, and also building off of lessons learned from other work that the three partners bring to the table. In terms of the challenges, the context is extremely challenging. It's a deprived area of Peru with specific challenges in terms of the population, high migration of young individuals for a certain period of time coming back, the mining industry and all that brings. But that said, the challenges in that context are also addressed through involving different partners with different skills. So the academic skills, the more community mobilization skills, and others. And I think just coming back to the approach and also building off of the tool that was presented, our aim is for our colleagues from Peru to come to Switzerland and share their experience, both in terms of the partnership itself as well as what's been found, to try to get insight from a wider array of Swiss experts, especially at the University of Geneva and University of Geneva hospitals, to see how we can address this complex issue in that setting. And also build more on this institutional partnership, because I think right now the partnership is more on an individual basis, and how can bringing people from this project to the university hospital strengthen the institutional link in terms of widening the discussion beyond just the people who are immediately involved in this project.
Thank you. So my name is Gilles Wandeler. I'm a physician at the University Teaching Hospital in Bern, infectious diseases doctor. And the partnership that we are fostering is between two university hospitals in Dakar, Senegal, and our hospital in Bern. And it focuses on hepatitis B testing, management, and training for management. And so hepatitis B affects about 10% of the population in most West African countries, which is much more than HIV, right? So it's about 10 times more hepatitis B infections than HIV infections in Senegal. And still very, very little is done at the moment. Less than 1% of these patients are currently diagnosed, right? So the project that we're running now follows one of those startup projects from Esther, where we sat at a table together last year with the different stakeholders around hepatitis B care in Senegal, and discussed the important barriers and the important challenges around management of hepatitis B infection. So we found out that what happens after hepatitis B testing was probably what was most challenging. What do we do with patients after they're diagnosed? And so we took advantage of a new program at Bern Hospital from our hepatology colleagues, who are now starting a certificate of advanced studies in hepatology basics, where they teach doctors to perform ultrasound measurements and liver fibrosis assessment and liver biopsies. And so we plan to have several doctors from Senegal coming to have this teaching here, and then teach other colleagues in Senegal. I think that we talked about startup funds just before. Luciano was talking about that and saying that this was a good way to bring about new collaborations and new ideas. For us, it wasn't really what happened, because it was a long-standing relationship we had with the Senegalese doctors, mainly around research. But for us, it was really about gaining momentum about a specific health issue. And I think that this was maybe one of my first lessons, is that to bring people together from different areas, be it public health, ministries of health, doctors, etc., around a specific topic, to gain momentum around something, was really very important here. And this is how we got the Ministry of Health, for example, on board, who did not do anything on hepatitis B up to now. It got them interested, and I think that was one of the main part of that first aspect of the project. Then, of course, having people participating, discussing and deciding on which steps are important is very important for the project. It brings them ownership of the project and makes them much more interested in it. And I think here the specific example that we had is the fact of bringing civil society and patients associations to our meetings, which is not the first reflex that a physician has when he sets up a meeting. But we did that, and we had a very influential president of the Hepatitis B Patients Association in Senegal who came to the meetings, and we were trying to find out what were the most important topics that we should address with that project. And he just came to the meeting and said, you know, to me it's clear, to me I struggle with the patients because I need to find them the best package in terms of cost to have a decent workup of their disease. And so this is what you need to address. So after a few hours of discussing with doctors, we still didn't have an idea, and there, after 5 minutes with that guy, we knew what we had to do. And so this is what we focused on, basically training doctors to learn how to do these techniques and then bring them to Senegal. I think maybe in terms of challenges, even though we haven't started the training program yet, and it's just in a really start phase now. But I think one of the problems we had at first is that we took the interest and the involvement of health authorities for granted. We knew it was a very important health problem, and we thought, you know, as soon as we'd come with that topic, then everyone would be on board and things would happen. And this was clearly not the case. So you really we had to take into account the political aspects of the different health issues and make it somewhat sexy for the health authorities, for them to really then start participating. So not only about what is clear to us, you know, it's an important health problem, but also try to find reasons why, for them, also for the political agenda, why health authorities would like to participate in that. And then finally, often specifically when we talk about research, but also about state-of-the-art clinical care centers in Switzerland, for doctors that are involved in that, it's often much more motivated to wanting to participate.
Thanks. It's nice to be last because all the three previous speakers have raised issues that are very, very present in the project that we're involved in. I want to say right at the outset, we do not have an institutional health partnership project. We were lucky enough to have a startup grant from Esther Alliance Switzerland, where we wanted to explore starting up a partnership. So the setting is in Papua New Guinea, which most people will not know. It appears most people in Switzerland don't know where Papua New Guinea is. Most people think it's in Africa. Papua New Guinea is in the South Pacific region, just north of Australia, and is the largest of the South Pacific islands. It's a middle-income country, but it is one of the countries in the world with the poorest health outcomes. And the project, and where we start off from, is that we are actually involved in a research project, part of which is funded by an R4D project. And the project is about whether we can improve pregnancy outcomes and neonatal outcomes by providing point-of-care diagnosis of sexually transmitted infections for women during their pregnancy. And the background to that is the fact that Papua New Guinea has possibly the highest prevalence of STIs during pregnancy. So 25% of women have either gonorrhea or chlamydia in pregnancy. 14% of births will be preterm or low birth weight. So really, really poor outcomes. And we're providing point-of-care testing in a multi-center within Papua New Guinea cluster randomized controlled trial. So coming from my background as a sexually transmitted infections doctor and epidemiologist, we wanted to, and with partners from Australia who are the PIs of the main project, we wanted to strengthen and improve this partnership, particularly in Madang, which is in one of the trial centres, and in a hospital, the main provincial hospital called Modilon Hospital. And so we talked about ideas about what this partnership could involve. And building on the STI part of the project, wanting to extend our involvement in sexually transmitted infections, recognizing that actually antimicrobial resistance is another globally important health issue, made a suggestion that we might build on trying to do antibiotic stewardship within the hospital, within the gynecology department to reduce antimicrobial resistance. And so the first lesson about what doesn't work is having an idea and presenting it to your partners. And I think, as Gilles said, saying what you think would be a good idea, and actually that's not where your partners are at all. So the answer is that we will not be doing a project on antimicrobial resistance. What all the three panelists have said is that it is really what works is listening to what the people in the country know and want. That's where they are. It turns out also that an STI project, STIs are very, very sensitive. We know that in every single country. And in countries where STI rates are so high, you would think that people want to talk about them, need to talk about them, need to do something about them. Actually, that's not the case. They're very sensitive, very difficult to talk about. Sexual behavior, domestic, gender-based violence are very, very difficult areas. So what did work was talking to the partners in Model on Hospital about what they were working on, which was to develop better screening and management of cervical cancer, where there is no screening, no late-stage management, no palliative care, but the gynecologist had off his own bat, funded and raised funds to develop an outpatient clinic for screening women for cervical cancer. So that's the what works is really about communication and talking to people. What didn't work, and what I think is still a challenge, is coming from an academic environment and coming based within a research project and wanting to start up an institutional health partnership between north-south settings, is that the partners still very much think that we want to start research, and if we want to ask for funding, then we're having to ask for funding for a research project, and that it's going along the lines of having a PI and having objectives and methods. And really, what they actually want and need is our job is to work with them to show them that they can say what they need for the health partnership and not to have to dress it up as a research partnership. That's what we want to be able to do. On a very, very pedestrian level, what doesn't work is physical communication between Switzerland and Papua New Guinea. About half of our Skype calls we have to abandon because we can't make a connection, and we can't connect by phone because none of these very, very clever ways in which you do free phone calls. Papua New Guinea is on no one's list for having a dial-in number. So we do it by phone, but we pay for it. So anyone who has any solutions about low-cost and effective ways of keeping communications going would be very, very welcome.
Working with people have different interests, they're living in a certain setting. So knowing the setting when you are coming, especially from that country, is helping you to make the bridge between the institution in the north and the south. I think these are very important things, working with people from the countries, maybe here. And we have several doctors coming from Africa, actually, running a project. And I think this is also something that I find fantastic because it helps really to have effective partnerships. And then how to move from people to institution. Yeah, this is also a very important point. As you say, David, a lot of times those partnerships start from people, meeting someone, maybe a friendship, but then how do you move up to institutionalizing the partnership? Working, including the community, really making that the community understand what you are there to do and what do you want to do is a central element to get the project to be successful. Bringing together all stakeholders.